Okay. SeneHealth has been a longtime partner of MHPA. We appreciate their continued engagement in support of MHPA and our member plans. Hannah will be holding a roundtable discussion entitled How to Improve Quality Measures and Reduce Disparities in Medication Adherence. I'm excited to welcome and introduce today's moderator, Sebastian Sager, CEO and co-founder of SeneHealth. With that, I'll turn things over to Sebastian.
Patrick, thank you so much. And thanks to MHPA for having us. Thanks also to our guests. This is a high-powered crew, absolute experts in several areas. We have physicians, we have pharmacists, we have public health experts. Every single one of our panelists is playing a major role in health equity improvement. We also have technology experts, we have quality experts and data experts. So this is quite the panel. So as Patrick mentioned, my name is Sebastian Sager, CEO of SeneHealth. We help people take their medication properly. We do that with two-way video recording. So think of it as like Snapchat for helping people take their medication. I'll ask each of you to introduce yourself quickly. Let's start off with Dr. Harrington.
Great. Thank you so much for that introduction, and thanks for having me today. I'm really excited for the discussion. I'm Rachel Harrington. I'm a senior research scientist at the National Committee for Quality Assurance. Folks might be familiar with us for our accreditation work, HEDIS quality measures, but we also do a lot of research evaluation and policy work as well. I focus on our health equity portfolio, and that includes our measures as well as our research and other areas there. So happy to be here.
Thank you. All right, Dr. Davis.
Good afternoon. I'm Dr. Tracy Davis, Director of Pharmacy at AmeriHealth Caritas, DC. I am also the new president of the Northeast affiliate of the Academy of Managed Care Pharmacy. My passion is the patient experience, and I am very interested in health equity.
Awesome. All right, Adamika Arthur.
Good afternoon, everyone. My name is Adamika Arthur. I am an epidemiologist by training. Ran hospitals for about 15 years, very instrumental in the 2005 state of California expansion of Medicaid, which undergirded the ACA in the early 2000s. And I'm the CEO and Executive Director of Health Tech for Medicaid. We're a convening body dedicated to supporting innovation in Medicaid, and we sit at the intersection of where health equity and tech equity come together.
Great, and nice to see you again for the third time in about 6 weeks. Dr. Kirk, thank you for joining us. You're up next.
Great. Hi, everybody, and thank you, MHPA and Scene for this. I'm with United Health Care in the community and state or Medicaid line of business. I'm the VP of Clinical Strategy and also a pediatrician. From a United Healthcare standpoint, my job entails the entire suite of clinical strategy, including strategy to improve medication adherence across the life stages. But as a pediatrician, probably my guiding passion is really to help the next generation be healthy. And so this work with Scene and MHPA has really been integral in that.
Great, thank you so much. All right, Dr. Nelson.
Yes, hello everyone. Happy to be here. My name is Anikia Nelson. I'm also a pediatrician by training, but currently working at Clarify Health Solutions as Senior Director of Clinical Product Management. And as we are creating the platform to power value-based healthcare, my particular passion is using value-based care to incentivize and promote health equity. I think it's a really untapped opportunity for us.
So MHPA, you did a great job in bringing this group together. So one more time, thank you. All right, so today's topic is surrounding medication adherence and the quality measures that are geared towards improving medication adherence. So I listed those separately. Medication adherence means the extent to which somebody takes their medication properly. And the medication adherence measures, so STARS or HEDIS, are intended to be a proxy for whether somebody's able to take medication properly. So the extent to which these two worlds connect is really important. So here are two, just as, our panelists will go into the detail and the depth, but here's a way to simplify it. If you do not have medication, then you can't take it. That's the first fact. And the second fact is, if you have medication and don't take it properly, then it will not work. So this is a very famous quote, kind of misquoted from the Surgeon General Koop back in the 80s, that last one. And as we know, in Medicaid especially, social determinants of health present real barriers to actually succeeding on medication. So those are the topics that we'll get into today. First question is going to Dr. Harrington. So you've got a great quote. Quality is used to tackle hard healthcare problems. We know that medication adherence is one of those. That's from a podcast called, I think it's called Measures Matter. It's on the NCQA website. But Dr. Harrington, we know that the current medication adherence measures are based on possession, refill. Do you have medication? Which is great, it's important. Looking ahead 5-10 years, where are these metrics going to take into account the second piece of the puzzle, which is you've got to take medication properly for it to work?
Yeah. So I think one of the big opportunities here is to take streams of work that have been separate so far, work on medication use adherence, work on social needs and unmet social needs in the equity space, and also work that's ongoing around how we think about quality measures. Whose perspective is centered in quality measures? Is it the system or is it the patient? To take those three areas and really bring them together. So are we thinking about medication measures in the context of the unmet social needs that people have and how they might modify their ability to both access their medications and to take them properly? So primary, secondary in that sense. And then, as we're measuring it, we tend to take these very broad population approaches to quality measures for good reason. They're used in programs that cover broad swaths and they need to speak very generally. But, with the availability of more nuanced clinical data, with the availability of more direct patient response data, can we use that to tailor our quality targets in a way that's most meaningful to people? And then, look at our outcomes in an associated way. So I think there's bodies of work in all of these areas, but where I think the real opportunity is, as we look ahead a couple of years, is bringing them together so that we're approaching measurement in a more nuanced and complete way.
So you mentioned just now talking directly about the patient experience, the individual patient, and of course these measures are population, based, and that's their intention. But for example, Dr. Kirk, you're dealing with programs directly, facing patients. How do you see what Dr. Harrington said in terms of from the individual patient perspective?
Yeah, thanks, Dr. Harrington. I think I'm going to attack this from three different angles. The first is really to go back to sort of the role of the pediatrician and the experience of pediatricians on the front lines. Our care is truncated to a very small segment of time that doesn't take into account the full experience of people or families. Clearly, it's in 15 to 30-minute blocks. Maybe you're lucky with a 45-minute block. We've got the opportunity for telehealth for sure, and that has helped give a window into the home environment. But in the clinic setting, there's very little opportunity to truly observe therapy being given, and particularly for those when they're going through a crisis or they're going through an exacerbation of their illness like asthma. Getting at the root cause really requires deep investigation. And that can be at social factors that are happening in the home. It can also be relational to emotional and mental health issues. So really having an opportunity to have the expanded root cause of what's going on that can occur through video-assisted therapy and tools and techniques helps us sort of expand the clinic outside of the walls of the clinic itself. And kind of just to go back to sort of kids in managing, say, asthma, this really helps them with ownership and agency. This is true for adults as well, but it gives them through the lifetime of their developmental continuum the opportunity to really take into control their own chronic condition or need, and be able to develop mastery and a sense of control over the symptoms that they're having. So from a perspective of the pediatrician, I just see this as an augmentation of the full care and healing delivery system that's really important. And then from sort of a quality perspective, you already brought it in, right? We've been measuring essentially just the sort of pickup and fills from the pharmacy, which only gives you one half of the perspective and certainly doesn't give you the perspective of whether patients have actually taken the medication. But more importantly, for inhalers and things that need spacers for kids and other aspects of medication adherence that we cannot observe through medication fill rates, we really need a much more comprehensive approach to looking at that from a quality perspective.
Absolutely. And I think we can get there. So technology has advanced, our understanding has advanced, and a lot of health plans are performing on these metrics, right? So it is time to take the next step. All right, Dr. Davis, you have a really diverse background. You are a pharmacist. You've worked on the health policy side. You're now at a health plan. What's your perspective on strategies that are actually working, whether they are quality strategies or direct patient care, as Dr. Kirk alluded to?
Thank you. I would say definitely connecting with patients and understanding their needs, their barriers, and their goals. I think a lot of times the patient's goals are considerably different than what our goals are for them. Often they don't understand the goal that we have for them, and their goal may just be something different. So I think that's a great baseline for care. I also think that there's an opportunity to engage with pharmacists and other people in the healthcare team to multiply the physician's abilities. They can support with education and also side effect management. I also have seen in other states, they have collaborative practice agreements between pharmacists and physicians, so it can take a lot of the burden off of the providers in terms of managing chronic diseases. Another thing also would be the way we do our benefit design in pharmacy. So from my perspective, I do shift different things from the medical space to the pharmacy space so that patients can pick it up a little easier. So things like continuous glucose monitoring, blood pressure monitors, blood glucose monitors, also promoting remote visits and telehealth visits, so that those monitors that we give them actually feed back into the medical record so that the provider is able to really have a robust conversation with the patients. Those are all the things that I think really do, what that I've seen really shift the way our patients engage with us. We also can continue to offer dietary support and fitness opportunities as a health plan. But I do think, you can look at a measure, you can have all the data you want, you can create a program. The biggest challenge we see across the board is how do we get people to engage? So it's like, do you answer the phone when your insurance company calls? Do you open the letter from your insurance company? I mean, you're an educated professional. Do you engage in that way? And so if you don't, then how do we get someone who maybe has other things on their mind to engage in that way?
Well, both you, Dr. Davis, and Dr. Kirk mentioned the provider's role, right? And I think you're also implying other strategies, Dr. Davis, which they could include potentially boots on the ground type of community health approaches. Sounds like that. I think I'll actually ask Dr. Nelson to jump in, since when we talk about these quality metrics, we're really talking about health plan quality metrics. The provider is playing a huge role, as we just heard, and Clarify is bringing value-based technology to value-based care, bringing some order to how providers get included in quality management. So maybe just a few reactions on what you just heard, Dr. Nelson.
Sure. I think especially what Dr. Davis just described is a very holistic approach to the problem, the big multifaceted problem of medication adherence. And I think we'd be remiss if we didn't use technology, which is light years ahead of healthcare, to really help us in this issue. So we can build very precise and actionable quality measures, but that requires clinical nuance. So we have to understand how we can capture the factors that influence what's actually happening in the patient's experience. And that includes social drivers of health. So for example, at Clarify, when we are building measures and when we're building benchmarks, we're not only considering the claims data, but we're also using very precise case mix adjustment to account for over 600 variables at the patient level. And that includes social drivers. It includes transportation challenges. It includes, do you live in a food desert? What are your comorbidities? So we can really accurately create a benchmark for comparison. And that way, once we have those nuanced measures, in addition to the right data, we can start to surface some of the inequities that were previously hidden and some of the issues that Dr. Davis was bringing to bear. If we can't see them in our measurement, then we can't really design solutions that address them.
I think that's actually pretty well said. In that, so while you were speaking, I was thinking, well, how is this relating back to the quality measures for medication adherence of the future? And the fact of the matter is, if you can't measure it, you are not going to be able to design metrics against those goals. So certainly capturing all those issues that could, and remember, the conversation is focused on succeeding on medication, right? So how are we going to tackle those issues, social determinant related, if we don't have them captured, right, in data? All right, so next up, you've heard all this, Adamika, and you have created an organization that brings together the technology community that's serving Medicaid. And so you've got, let's say, pole position on all the innovation that's happening geared towards a population that really needs help. I love the fact that you bring the patient perspective as well, or let's call it members probably better. So from your perspective, how do you see metrics evolving to capture what you see on the ground? And also for background, Adamika has been in public health her whole career. And since Seeing Health started in public health departments, I feel like that's our bond right there, that we both understand this world so well. But the floor is yours, Adamika.
Yeah, and I'll talk a little bit about that. One, I want to recognize the great comments that were talked about before, really talking about the pharmacist role, talking about what we need to do to incentivize individuals on Medicaid to actually participate, that engagement factor, right? And also like the complications. And I think since our audience is MHPA, which I know deeply, and I know we're kind of preaching to the choir, one of the things, and Health Tech for Medicaid has been around for about 5 years now. I think part of my frustration as a hospital leader was really understand that there's this new wave of innovation, yet there was a real disconnect. Many of our innovators didn't see the Medicaid population as a customer base. And to me, that was really quite shocking. And so that's kind of our roots, but we center all of our work, kind of equitable, inclusive design lens, specifically on people on Medicaid and their caregivers, right? And so when you look at a population of 91.4 million people, and you think then about medication adherence, it can get up to be a little complicated, right? There are certainly different subsets that you're going to see amongst the population, but there's a few things we know really well. One, we know the impact on medication adherence on health services and how it really does drive increased and improved medication adherence in Medicaid, improves the public health workforce system, right? We also, and I want to think in triangulations at some point too. We also know that there's a huge effect in the reduction of copays on drugs, on pharmaceuticals, right? When people are utilizing them correctly and safely in the right way. And then we also know that medication adherence impacts star ratings, and star ratings therefore impact, at least in the environment that we're talking about, increased quality scores and increased finances going into the health systems. So when I think of the triangulation between kind of where public health sits, the providers sit, the payers sit, and the tech solutions that are helping mobilize things in the middle, you really want to see how it is that we can create these win-win-wins, right? And I think by having solutions that really are focused on the members, recipients, beneficiaries, or I just call them people's needs, right? And that is really meeting people where they are with a product that they can engage in very easily, with that true range, right, of birth to death that we see in Medicaid. And I think for some that is maybe a very quick visit. For some, it's an emergent communicable disease interaction. For others, it's a lifelong chronic illness. And I think having technology that I think is safe and efficient, but has a connection point that doesn't feel burdensome is really essentially the best way for folks to engage in these sorts of products. And I think in the case in where you're improving the community's health, public health departments are really incentivized to keep that moving, right? When the provider's life is made so much easier because the information is in there for you to actually determine that what you've prescribed people have gotten. One, they've picked it up, right? But two, they're actually taking it. And then it can reduce that level of noise in their clinical life. And then for payers, obviously, like the national medication adherence is less than 33%, even, in this high wave of telemedicine being a little bit more adopted. And so, I think a lot of payers in the audience are really looking at ways to increase their star adherence, which increases their ability to get more higher quality scores and more value-based payment back into their ecosystem. And I think that in itself is a win-win-win, really looking at solutions, tech solutions that are not overly complicated, that everyone seems to win.
Excellent. Excellent. Excuse me. All right. So from the technology perspective, I'll give you guys a very surprising piece of information. We wouldn't think that our public sector is leading the way always in innovation, but sometimes they are. So on Friday, the Center for Disease Control announced that video directly observed therapy, this is an adherence strategy for tuberculosis management. So in tuberculosis, you have to have an observation on every dose of medication taken, right? They announced that doing that via video, whether that's video recordings or whether it's live video, is equivalent to watching somebody in person take their medication. So this 50-year-old public health strategy is now a standard of care, which I find incredible that that can be done in one fell swoop with a statement by the CDC. There was tons of research to back this, of course. So maybe with that in mind, Dr. Kirk, there are a few themes that have come up here. One of those is social determinants and being able to measure them so that we can attack them. In your practice, perhaps you could, thinking about that kid in East or West Baltimore, the butterfly Baltimore, geographically, exactly where patients are, patients to the ED are coming from in Baltimore City. What are the social determinants that affect a child's ability to succeed and avoid the ED in asthma?
It's a great question. Thanks. Well, first, I want to say it's about time for the video observed therapy to give patients and families, frankly, the option to be able to use the technology that we all now are using to be able to connect with each other, and to reduce that burden on patients, frankly, that are really dealing with a significant illness and diagnosis, so that they don't have to be seen at a public health clinic or other place for direct observed therapy. Just to go back to sort of the last comment from Anika on the elements of the win-win-win, it's really that intersection of the Venn diagram, and I'm going to pull that full circle to really enabling the provider We want to make sure that providers are centrally located in this caregiving relationship because they are, the healers and the caregivers that we entrust ourselves and our families to. And I would include that definition to be very broad, includes, in this case, in terms of asthma, our respiratory techs, our pharmacists, our nurses for certain, and our CHWs, our many caregivers in that continuum. To your question about what sort of is driving the social determinants of health for patients that I've had the privilege to serve, and certainly the members and patients and people that United Healthcare has the opportunity to serve, they're multifold. The first is taking from the lens of families and children. There's determinant of transportation for certain. There's getting to the pharmacy that's in your network. And there's also the fact that people have complicated lives. They may have multiple caregivers. They certainly for children, they have school environments. And if you take into example asthma, to have your inhaler, you really need to have your rescue inhaler and presumably your controller inhalers in environments where you normally are. And that would be your school and your multiple caregiver settings. And that can complicate kind of the ways that we think about quality measures, because we're looking at a different kind of fill rate when you're looking at multiple inhalers for those types of needs. And that's just a lived reality for families, is that you want to make sure that they've got what they need at the place where they are. And that's certainly like an ongoing conversation that I've had with patients. So it really just gets to the point that you have to have a real true sense of investigation of what's going on with people and their families in order to really address the needs that they are presenting with.
I'd like to add something there. You didn't know, but I'm from
Go for
Baltimore.
No, you guys go for it. You're the experts here.
So I would say in terms of the social determinants of health, I think the prevalence of marijuana smoke in our communities right now is overwhelming. We smell it everywhere. You also have families who for generations, cigarette smoke has been a part of the environment. So if you want to go to the family cookout, you're going to endure Uncle so-and-so over there smoking. So if you're a child or you have asthma, that just becomes another thing that you have to kind of get around. I would also say the caregivers often have asthma too. So it's like, are they educated on how to use their inhaler? And so a lot of people with asthma in the family, they've had family members pass away from asthma. So then there's a hesitation to even engage with the healthcare system at all. So there are just many challenges. And I happen to work in DC, but be from Baltimore. The challenges are the same. It doesn't really change as you drive down on the street, but it is very, very challenging, trying to get our arms around asthma. I know several years ago in my health plan, we did start a program with the Children's Hospital here where we were giving 2 inhaled corticosteroids in addition to 2 rescue inhalers, 1 for home, 1 for school, because we knew that over the weekends, kids are going different places. And if we could just get that inhaled corticosteroid in them daily at school, we would reduce all the ER visits and everything else. And we really did see some growth there, but it is very similar to what I said earlier. It's hard to get people to engage. So with the small group that we had, it went well.
I just want to jump in and say, I couldn't agree with you more, Tracy, on this use case specifically, which is asthma. I live in Oakland, California, so across the country, but very similar demographics, right? Very similar issues as it pertains to especially our young children on Medicaid. But I think that one of the things that was noted most importantly was really about their caregivers, right? What we know about Medicaid caregivers is they often die before the individual who's caregiving for the person. And that is not just a child-parent relationship. That is also in our dual population, et cetera. So I think one of the things I love about this conversation is the power of what what we call, VDOT or video direct observed therapy will do to use cases and how that will push the boundaries. And I like to think of determinants of health as not only social, but political, environmental, ecological, and there's so many intersections. And I think that there is some power in using evidence around directly observed therapy. I will just say, Sebastian and he actually may still be in Tennessee. I just came in from being in Tennessee, and the amount of just direct cigarette smoke was, and I'm an asthmatic, but I really rarely ever have to use a rescue inhaler, but just due to environmental stimuli, different environment breeds different needs as it pertains to your own health. And so I just love the fact that not only in tuberculosis, but we could be starting to look at other use cases, not necessarily only in communicable disease, where we can see how directly observed therapy really intersects in a way where we're being more person-centric, and we're designing for how our delivery systems can actually work well in populations.
Yeah, and sorry, Sebastian, I'm
No, I was unmuting to point to you. So go for it. And then I'll have a question for you too, Dr. Harrington.
Oh gosh. Okay. So I think just tying it, I think we're hitting on so many really fundamental things here about how care and health actually work, right? And tying back to Dr. Kirk, a point you made around being curious about how all of this is impacting the data that's used in the quality measures. I can say I've been on the side of this where we treat some of this as known limitations. It's almost like when in a publication you disclaim your limitations of your data. We say, oh, well, we don't know, somebody may be stockpiling the medication. They may be, handling their dosing differently at home for a variety of factors. And I think historically we've just treated that as, oh, it's a fact of the data. And what we have a chance to do here now, that data reflects real life choices. It reflects decisions that people are making, and it's not random. And that's where this information on the social, the environmental, the political, the structural factors that are in play can explain or help to explain those choices in a way we've never been able to do before. And that opens up so many possibilities, because instead of writing that off as a measurement error and you can't see it and you just kind of keep going, you take a step back and you say, okay, why might we be not seeing a fill here? It's because it's being treated this way. And that in and of itself is a quality signal. And how do we use that to direct care? So I think that's where this gets so powerful, as you can bring it together. And you mentioned, you wouldn't expect Medicaid to be the innovator. In this data area, especially in the social determinant, social needs data, Medicaid is. The states are at the forefront of requiring that data collection, managing that data collection, incentivizing partnership between community organizations and the payers and the providers. So I think Medicaid, almost more than any other payer, is really in a position to take part in this revolution.
I couldn't agree more. I'm going to jump in, Sebastian, before you can say your other question. I think that there is an opportunity here, though, where we can really look at tech enablement as a solution set, which we often have not done in traditional public health spaces, in traditional Medicaid ecosystems. And I think that is going to take things like this, where, we know that VDOT is going to assist health departments in meeting that standard of care, right? But it's also going to be more impactful for patients themselves, their quality and duration of life, their lack of transportation and getting in, their missed appointments, their waiting in waiting rooms. And so it helps us all utilize resources more efficiently. Now, by doing this and making this available, we also then have to do the other side, which is there are many people who don't have the appropriate literacy, tech literacy, digital literacy, actual broadband to actually, go and have a bi-directional video visit, or but we can also utilize things that we already know. So it's like our phones. Most people, the latest results said something of the effect of like 92% of Americans utilize some sort of mobile device. Now we can talk analog, we could talk scalability around not them being necessarily smartphones, but when we make reports like the one that was done 6 days ago, we also then can stretch what is our evidence in these treatment areas and in additional use cases to actually improve people's quality and duration of life.
Yes, all this is great. And the reason I was unmuting to talk to you, Dr. Harrington, is that when Dr. Nelson was talking about all the data that's collected by Clarify Health. I said something, and our VP of Marketing, Stephen Cupworth, quickly messaged me, and he's like, hey, wait a second, you just plagiarized Dr. Harrington, who said, we need to measure, right? We need to know what we're dealing with. You can't improve what you don't know. What's measured matters, right? So essentially, I inadvertently took your quote. But I do think the question I was going to ask you is, in asthma, quality, there is the metric asthma medication ratio, and that's intended to improve the proportion of controller to rescue. So if a kid is using a controller, then in theory they don't need the rescue as often. But I love this conversation about the exceptions to the rule, right? Where behavior that's being taken by the member is actually logical and should be maybe even encouraged, or there's something that the health system is doing that's going against your metric. As an example, sometimes pharmacists will give the controller and the rescue automatically, right? It gets automatically delivered or automatically put in their hand, and now this ratio is skewed. Or then the other like really down to the finest detail is the child's not using a spacer, let's say, or they don't know how to use an inhaler, period. So, and then all these school situations with, one inhaler at school, one at the mom's house, one at the dad's house, et cetera, like these are all exceptions to these rules. So I think what Dr. Nelson is capturing is really, really interesting. And I think this entire effort to capture the data now, it starts to make a little bit more sense from my perspective anyway. So Dr. Nelson, you've listened to everybody talk. Any commentary?
Yes, absolutely. Lots of thoughts. I think one thing that we've all been mentioning indirectly is health literacy. Adamika talked a lot about different facets of literacy, and I think health literacy is one that we need to focus on, not only in the direct patient care situation or scenario, but also in how we measure quality. Because health literacy informs medication adherence. It informs, whether I'm cutting my pills in half to make sure I have enough medication, without knowing the impact of that. And when patients have an accurate understanding of their condition and the need for their medication, they're more likely to comply with their regimen and do so correctly. And I think we can even think about this as an extension of informed consent. Is a patient really informed when they are prescribed the medication? And what's our responsibility as providers to really understand that?
Well, and I just want to say, you bring up a really good point. It helps us figure out what questions we can ask. So now that we're not burdened with, and Dr. Harrington, you talked a lot about the clinician, right? Being, or not just the clinician, but the care team itself, right? Being the center of what we'd like to see with our patient-people relationships. It now unburdens, it unlocks, when some of this other work is being done, it unlocks the ability for us to start to ask the right questions, right? Because health literacy is one thing, understanding that literacy is another. And then playing back that information, digital literacy. If we're going to be using video, right, we need to understand that people know how to do that or how they're getting there. A lot of what I learned, like in the early pandemic, when we got deployed to go help in New York City to help with NYCHA buildings that had no broadband whatsoever. We learned a ton in New York that really told us that, like, sometimes people were using a neighbor or waiting for someone to get off work to help them actually. And because the video was set up right. And because they were there for their appointments, we didn't understand there was other people necessary for them to get what they need. So there is a bit of tech literacy, digital literacy, as it intertwines with our understanding of health literacy. And this unlocks an opportunity for us to start asking questions. Also, the power of video. And I don't know, Sebastian, if you guys can talk about that, but I'm almost interested in what is the power of what we see in video elements to, like, see the conditions of individuals' homes, to see what they need outside of what we could actually see, or the power of what we could see inside of a 15-minute or 7-minute visit.
Yeah, well, my reaction there would be that maybe 50, 60 years ago, this is my impression, having just studied and tried to understand what's happening. There were maybe fewer people. There was more time with physicians. There was more time with nursing. And so a lot more care was delivered. There was more time for care, is my understanding. So if you had a heart attack 50, 60 years ago, you might be in the hospital for longer than today. And some of that has to do with how surgeries improved or technology
In
used
certain
for some of the-
populations, couldn't agree
What's
with you
that?
more.
Yes. And so I would say what video opens up is just an ability to deliver more care. So I don't think that the care changes, right? Like it is a standard of care in asthma for a child to be able to demonstrate back that they can use their inhaler, right? So now how are we going to affect that standard when we don't have the time, right? When a child, the fact is it takes a kid, in our experience from literature, what I've read, about a couple of weeks to learn how to use the inhaler properly. They got to do it 30 times and then they understand it. But who's there to coach them? So I see the power of technology for me is to deliver the existing standards, to fulfill the pharmacist's instructions, fulfill the physician's instructions, the nurse's instructions, and enable those, that care to get delivered in a world where we've cut down the amount of care to minutes, right? That's how I see it. One thing on that note, just coming back to Dr. Nelson, just want to call out, is a physician who is a clinical product manager. So not just a doc who's seen this, but actually designing product, which I think is an incredible step in terms of technology. Like having like we always work with a lot of like Dr. Kirk's team or researchers to get that physician point of view, but having it directly in the product team, that is huge. And that, I think that gets to answer questions like, well, how do you use video to deliver care? Well, great to have a physician tell you who's designing a product.
Absolutely. I think it goes back to what we mentioned earlier in the webinar, which is clinical nuance. So what factors do we need to consider as we're building technology to actually capture what happens in the patient care scenario? And how do we account for the limitations of and software engineering, the limitations of claims data? What clinical exclusions do we need to apply when we're building metrics to actually get at what's happening in healthcare? Because otherwise, you end up with metrics that are not reasonable and aren't trusted by physicians. And so they're not going to take action on anything that they don't trust.
I was just going to piggyback on this to say the sort of background conversation has really been around. I'll go back to what you said, Dr. Nelson, about the expanded informed consent. And I would say it's basically shared decision making, but what we're really describing here is the efficiency that we've built has made it so transactional that we're losing relationships. And what video or telehealth or virtual visits give an opportunity for is maybe more space for that relationship in a way that's real, but it also has to honor where people are. In other words, if you're going to be viewing someone's home, recognize that that's also a trust. And if you're going to recognize that there are social determinants of health, what are you doing to close the gap? And that's where, I would say providers have been really talking about how they're screening for social determinants of health, very much interested in how they are supported to close the gaps in care. At United Healthcare, this is central to our strategy to ensure that we have an opportunity for every member, inbound or outbound opportunity to screen for social determinants of health. And then how are we linking for closing the loop? So part of that requires that we lift up and build the community-based organizations that are doing that support, because they're not, they don't have endless resources either. And then just connecting the dots and how communities themselves support each of our families and members. Back to your point on, there's lots of people in the apartment building in New York that were actually supporting connecting maybe a patient to a telehealth visit.
Yeah, I'm so glad you brought that up, Dr. Kirk, about the doctor-patient relationship, because I think if you talk to any clinician, number one, clinicians value that relationship. If you ask the clinician whether they want to spend time and resources on building the relationship with their patient versus all the admin things that they do, they're going to prioritize that relationship. And unfortunately, where we've arrived at in healthcare today is that the administrative burden is really outweighing that time and effort to build that relationship. And also technology has tended to come between the patient and the doctor. Let's say EMRs, your doctor is facing the computer the whole time that they're seeing you, versus this technology that we're centering today, the directly observed therapy via video and telehealth, is really using technology to help bridge the gap and bring that relationship back to the center. Which can only do, wonders for things like health literacy and addressing determinants and things like that.
On that point about relationships, I actually am thinking, Dr. Davis, something you brought up really early on in the discussion around we're talking sort of provider clinician relationships, the pharmacist patient relationship too. I think that's something we've been keeping an eye on, and there's sort of this developing interest in the role that pharmacists, pharmacy techs, the pharmacy setting plays in achieving high quality care. And if you think about it, this might be a little bit, over the top, but I don't know if there's any healthcare setting or healthcare interaction on the clinical side or on the interpersonal side that we touch as often as pharmacy, right? Like what other setting are you walking back into if you're not using mail order, like you're walking back into every couple of weeks, or that you are doing an intervention on yourself daily, right?
It's also a setting where we're not billing. We're not billing for each encounter. So if you say, I have a rash, you can come back, you can try 3 different creams and you can keep coming back and talking about your rash until you feel comfortable. It's a very interesting environment. I do think that unfortunately in the environment that I work in right now, in the DC area, our pharmacists are overwhelmed and they're not able to provide the care that they should provide. It's really unfortunate. I've been practicing for over 20 years, and I know that when I first started, my favorite thing to do would be to go in on a Saturday morning and get to talk to people about what was going on with them. And then over time, because of the technology, because of the requirements for adherence, because of the pressures from the company, most of your time, just like the providers, it turns into admin work. It really has gotten to be unfortunate. So when I encounter very complicated patients, I try to find them an independent pharmacy, because the larger chain pharmacies haven't been able to create a workflow that really supports patient education. All the pharmacists know, but in terms of having the opportunity to really share with patients, they just don't have it right now. They're overwhelmed. And then people are leaving the profession because of all the crime and all the challenges. People are kind of walking away.
Yeah, I think
certainly not an easy environment for modern care right now, and there are so many aspects of it, but also some of the needs are so dramatic that you also wonder, well, should the pharmacist or the physician even be spending time with that? And in some cases, when there's social needs, there are certainly other types of healthcare workers who can fill some of these gaps. I also like just returning, and I think we'll get to questions after this, but there was a point made about the informed consent, like as if you're going to give somebody an inhaler, part of that giving them the inhaler should be that they actually know how to use it. So it's maybe a little tangential, but I love this example. When I was growing up, my parents just chucked me in the back of the car and started driving. Today, my 5-year-old tells me to put my seatbelt on. And if he's like, not paying attention, the car will force you to put the seatbelt on. Mm-hmm. So how is it that, and you all had mentioned, pharmacy, it's touching everybody. It's what thing in healthcare does a member do every single day if they have a chronic condition? They're interacting with medication, right? So for something this critical, you would think that there is some type of product design need that will force we'll call them an end user, if we want to use their medication in the right way, right? In the same way that we put product liability on cars and, every other thing you can imagine, right? The user is forced to use it correctly.
There's
But I think-
also certain inhalers like Dulera and Symbicort that don't have enough doses for monthly use. So you get into a situation where, as a health plan, you want to make sure everybody has what they need, but then everybody doesn't need it. It is very complicated when your manufacturer is not cooperating or making products that make sense. It's very challenging.
Right, and that gets back to this usability idea, right? Awesome discussion. There's a very practical question from the audience that you jumped in. Thank you, Tracy, to answer. I think this is very helpful. If you could give plans 5 to 10 concrete suggestions on how to improve adherence in their member population, what would you say? So before anybody answers, my initial impression when adherence was mentioned was adherence, the extent to which a patient or a member takes their medication correctly and consistently, right? So I'll leave it to you all to make practical suggestions for how a health plan can improve med adherence.
Well, I'm gonna
I
say
answered a
something
bunch. I
super
can't see
easy.
my answers now, though.
Well, I was just gonna say something very easy, which is we often ask plans how to improve adherence. Why don't we actually ask the people that are members? And that's kind of where we sit. We sit at the element of oftentimes we never ask the individuals that we're actually trying to serve what they need. And I would just say, as a convener, we get out of the way of having to, we're not a payer, provider, a policymaker, an entrepreneur, an investor, an advocate. But we really center what do people need, and then we can take the pain points of the other stakeholders and really start to break that down. So I actually index on like the basics of kind of equitable and inclusive design of any product, any system, any delivery system, any narrative change, and actually index on asking individuals. And you can ask them by you can slice that data a bunch of different ways to try to get a range of answers that is not so individualized that it feels frustrating. But I think that's where we need to anchor our work. And I think some of that's just my public health training, but it's also, it ends up being the investment that's best worth what people actually will use.
I'll go next, Sebastian. The 3 pillars that we really focus on, and so I'll make it 5, but it's basically three is empower members, evolve or enable the care ecosystem, and engage communities. And that really gets at your point in terms of, hey, what is the community or the member telling us, or the people telling us about what they need for medication adherence? But the empower really gets at, looking at social determinants of health, understanding that behavioral health is so central to medication adherence. If we're not thinking about how the spectrum of emotional, social, and behavioral health is integrated through chronic disease management for traditional medical disease states, then we aren't really addressing the true sort of spectrum of care. And then in terms of, quote, enabling the care ecosystem, that's really doubled down on the fact that, and I'm glad you have Tracy here representing the pharmacy community. We have to do this in conjunction with each other. And and clearly pharmacy is really the front door in many respects to all kind of provider care delivery. So partnering with our pharmacy providers and the numerous other sort of elements of the care ecosystem to make sure that we can kind of address the workforce shortages that I think Tracy brought forward, but just the sort of like elements of care. And then thirdly, engaging the communities. And that's not just hearing the community voice, but certainly is hearing the community voice, but it's also helping invest in the things that are necessary to keep communities resilient.
And when you ask people, tell them you're listening. Like, tell them this is what we heard. This is what we heard from how many of you, and this is what we're doing about it. And then adjust, right? As it's not working. But I do think that we often ask people and we don't, compensate them for their time or their energy or their effort, which is also problematic in my mind. But we also don't tell them we listened to them and we've made this change because of their voice. So not just blindly asking people, but really moving that into practice and telling them we're trying something we heard. We heard that you really want, safer spaces for you to have educational consults in the lobby. And so we've made this change and that's why it's different. And tell us what you like about it, what you don't like about it, and be transparent. I think that's another thing, is that oftentimes, while we talked about the clinical care team and the patient member person being in the middle, we often over-index that with our clinician teams or our care teams and not our actual member voices.
I'd like to add something, and maybe it goes without saying, but measure medication adherence and look at how you measure it, and stratify adherence by demographic factors, by race, by age, by social determinants, so that you can begin to surface any inequities. And then I take it a step further. When you do see those, because we know they exist, look at the mindset with which you're asking your next question. Instead of, why are patients from X community not taking their medicine? Think about, why are we as the healthcare system failing this group of patients?
Yeah.
Take it from an anti-racist perspective, for example, and that will enable you to design solutions that really get at the problem.
Just to piggyback on that, I mean, being part of some of these conversations in a quality organization, and we know it happens elsewhere, listen to the language you use to describe performance, right? XYZ patients did worse. No, they didn't. We served them worse.
Mm-hmm.
We failed at getting them the care that they needed. Why? Like, I think that framing, it seems like a surface thing, but it's not, because it does force you to ask a different set of questions and think about a different set of interventions. While I'm talking on the note of health plans, I would say don't forget structural things. We've been talking about a lot of quality measures, and a lot of quality is process and outcomes, and that's where we focus. But especially in the equity space, for us, going back to basics on structural measures, what are you doing in terms of your systems, policies, approaches, benefit design? How are you going about it? And get out of the way of your members. If, a lot of our benefit designs are there for a good reason, right? We know it's longstanding, but if you're finding that the way you have your mail order pharmacy cost discount set up is getting in the way of patients who live in a place that they don't feel comfortable getting mail order delivered, don't charge them $30 more because it's safer for them to go pick it up. Yeah. Right? Like, think about that and get out of the way of the patients, and taking it from the structural perspective can be very helpful there.
And I think, too, the structural perspective with providers, the payer-provider relationship, how are your incentives set up? Are your prior auth policies excessively burdensome? What's your formulary look like? And are providers really empowered to provide the care that they see fit, and that includes medications? How can you align incentives that promote behaviors or reward behaviors that promote equity in medication adherence?
This has been awesome. I think that the question was, how are we going to measure adherence in the future, right? Because that's where we are, because fact of the matter is, how are we going to measure the things that get in the way of adherence, and how are we going to measure that somebody was successful? But we are coming to time, so I want to leave you with just one point. So sometimes when we get to a topic like health equity, or Rachel, your point, like somebody is doing worse, it can be a very negative conversation. I want to thank Dr. Davis on email on keeping it positive here. What I will say is, we need leaders who are going to actually work on these things. You are all doing this work now, right? This isn't, you're not sitting there and complaining about it. You're helping patients or members or people every single day to get through big challenges in their healthcare. And it's a very frustrating thing because of the amount of time that we have for care. And then sometimes the metrics are really, incentives, and they're very complex to draft. And just saying we're going to measure it differently it's a very big enterprise to do that. So these are hard challenges, but we have excellent leaders on this call who are great role models for the rest of the industry to actually get to work every single day to make improvements to these things. So thank you all very much for joining. That was an awesome conversation. And also somebody said before this call, hey, there's a lot of women on this call, so we should give a shout out to Women's History Month. I didn't know it was Women's History Month, but it's good that I knew before the end of the month. So. Anyway, thank you
Got a few
all.
more days, Sebastian, got a few more days.
Exactly. We get 11, right? But anyway, I'll turn it back over to you, Patrick. Thank you so much to MHPA for hosting. Very appreciated.
Oh, our
Thanks for
pleasure.
all.
And thank you to Scene Health and the panel again, just to reiterate what you were saying, Sebastian. Great discussions. We very appreciative of your time today. And thank you to our attendees for your time with us today. And we hope you'll join our future webinars. Quick reminder, MHPA 23, our call for presentations is open. If you're interested in speaking, just go to our webpage, reach out. With that said, looking forward to seeing y'all next time. And again, thank you very much for your time. Have a great afternoon.
Thank you.
Thanks, everybody.